Good afternoon, everyone, and welcome to the Global Interdependence Center's executive briefing. Today's event, titled The Cure and the Disease Part 2, is sponsored as part of the David R. Kotok Global Healthcare Series. As a reminder, this event is being recorded. The replay and the slides will be made available on the GIC website later today. During today's presentation, if you have a question, please go to the Questions tab in the Go To dashboard, type in your question and hit Submit in order to get it into the queue. Joining us today are three senior healthcare and scientific leaders from the Montefiore Health System based in New York City. Dr. Andrew Racine is Senior Vice President and the Chief Medical Officer of the Montefiore Health System and Executive Director of the Montefiore Medical Group. He will be joined momentarily by Dr. Theresa Madaline, Montefiore's Healthcare Epidemiologist, and Dr. Barry Zingman, the Clinical Director of Infectious Diseases at Montefiore Medical Center and the Albert Einstein College of Medicine. Dr. Racine, as a very good friend of the Global Interdependence Center, I want to personally welcome you and thank you for joining this executive briefing.
Thank you, Mr. Kennedy, and I wanted to thank the GIC for inviting us to participate in this webinar. I hope that we're going to contribute to the understanding of the audience about what we've been through and how it's been going. My job this morning is to set the context for this, and I'm going to do that by showing you exactly where we stand in the Bronx and at Montefiore with respect to this, and then I will hand it back over to Mr. Kennedy so that we can hear more about the science of what's going on. So I expect now that you should be able to see my screen.
Yes, it's visible.
Fine. So I will then go ahead and explain that we started out with this as a picture of what the United States looks like at the beginning of this month with respect to the number of cases, cumulative cases per 100,000. And you can see that the disease is not evenly distributed throughout the United States. This is not going to come as a surprise to anybody in the audience. But the Northeast continues to be, as it has been all along, an epicenter of this infection. And I wanted to put some context into that by essentially showing the following slide. What this shows are the total number of US cases in the United States as of today. There are over 2 million cases. And it also shows which states have been hardest hit. You can see that Texas, Illinois, New Jersey, and California all have large numbers of patients, but New York City exceeds all of them. So even though the United States, with over 2 million cases, is the hardest hit country in the world by a factor of about 2, in the United States, New York City is the hardest hit state with regard to the number of cases, with almost 250,000 cases recorded to date. If you look at the number of deaths, the same picture emerges. The states that have the largest numbers of deaths are slightly different than the number of cases, but you can see that Pennsylvania, Illinois, Massachusetts, and New Jersey are not anywhere near the number of deaths that we've experienced here in New York, with 22,321 deaths. This essentially mirrors what goes on with regard to the case rates, and these are the case rates within the city. And the reason I bring this up is that even within New York City, the distribution of this pathogen has not been uniform. And you can see that when you're talking about case rates per 100,000, the Bronx has the highest case rate of any borough in the city. And the same is true of deaths. So if you're looking at deaths per 100,000 in the population, the Bronx has the most. All of which is to say that in the hardest hit country in the world, in the hardest hit state in that country, in the hardest hit city of that state, and in the hardest hit borough of that city, the Bronx has been the center of the epicenter of this infection. Montefiore has, at this moment, cared for over 12,000 patients on an inpatient basis for this disease. We have treated tens of thousands of patients over the course of this past several months, and we've admitted over 12,000 of them. And to give you just a brief overview of what the institution is, this essentially is a graphic of what the Montefiore Health System is all about. And I apologize, it's not the best graphic in the world, but it does give you some idea of that we have a large research enterprise in the Albert Einstein College of Medicine that's part of the health system. and we have NIH grants and the kinds of things that are associated with a large enterprise of academic stature. We also, though, have a very large medical clinical area with regard to the health system, and that includes a hospital system with over 11 acute care facilities, including a children's hospital, areas of centers of excellence. We have primary and subspecialty care throughout the Bronx and Lower Westchester and into the Hudson Valley. We also have a home care agency that delivers care to people's homes that involves lots of nursing care. We have an information technology platform, as you can imagine, that includes AI and machine learning. And then we have a care management organization. All of these things are to show that Montefiore is this very large healthcare delivery organization. And among those things, we have two very important participants with us today, Theresa Madaline and Barry Zingman. And I will turn it back over to you, Mr. Kennedy, to introduce them to the audience.
Great. Thank you very much, Dr. Racine. Please don't go far. We'd love to have you back for the Q&A. We have some questions for you. But let's turn to Dr. Madaline, who is the healthcare epidemiologist for Montefiore and actually helped to lead the health system's response to the COVID-19 surge in New York. So Dr. Madaline, welcome. Maybe you can just start off, it's been a short period of time, but we've learned a lot. What have you learned about the biochemistry of COVID-19 and how it's impacting the human body?
Sure. Thank you, Mr. Kennedy, and thank you to GSD for having me today. So I think we'll start out with a bit of biochemistry and then talk about the clinical disease and the epidemiology of this disease before Dr. Zingman walks us through some therapeutics. Next slide, please. Thank you. So coronaviruses are a family of viruses of which COVID-19 is a member. And they're named coronaviruses for the crown-like glycoprotein spikes on their surface. You can sort of see in this picture here that they have little spikes on the outside. They are large viruses, and there are 7 known types, and they range in severity of symptoms from the common cold. So there's 4 common types that cause the common cold, which I've listed here. There are other agents which you may have heard of that have caused global outbreaks in the past. So SARS, or severe acute respiratory syndrome, in the 2000s, and then Middle East respiratory syndrome emerged in 2012. And of course, we're all familiar now with COVID-19, which is caused by a virus called SARS-CoV-2. So the virology of SARS-CoV-2, it's an envelope virus. It's a single-stranded RNA virus with a nucleocapsid on the outside. And it has these glycoprotein projections, which I mentioned. These spike protein is what binds to the ACE2 receptor on human cells, and it enters the cells using a protease. The ACE2 is expressed on a multitude of human cells, which include cells inside the mouth and the nose, as well as the lung, the GI system, lymph nodes, bone marrow, spleen, liver, kidney, brain, and importantly also on arterial and venous cells and arterial smooth muscle, which will play into some of the complications that we're seeing of this disease later in my talk. The way the virus replicates is using a viral RNA-dependent RNA polymerase, which is important to know for the therapeutic part of the discussion. And the virus is released from the human cell by budding, so it doesn't actually destroy the human cell, but is released in little packets from the cell membrane. Next slide, please. The clinical symptoms of COVID-19 are in large part a reflection of the various different tissues that I just mentioned that carry the receptor for this virus. And we know now that the virus can cause a spectrum of disease. So not only severe disease, some people can be asymptomatic while others have a sore throat, fatigue. Some people can get a fever and chills, cough. Some people also get gastrointestinal symptoms, but not all. That frequently manifests as diarrhea, sometimes nausea and vomiting. And then one interesting feature of this virus, which many of you may have heard of, is that about 30% of people will complain of loss of taste and or smell as a result of the way that the virus interacts with nerves involved in olfactory senses. And some people can get sort of a congestion or a runny nose, much like a regular cold. Next slide. So as I mentioned, many people can actually be asymptomatic, and the estimates are that that can occur in up to 80% of people. For those who do have symptoms, 80% of those people will have mild or moderate disease, and that can include more of a mild case of pneumonia. 14% of people are going to have more severe disease, so that includes organ failure, like kidney failure, liver injury, or other cardiac issues. And 5% of people who are symptomatic will be critically ill, requiring an ICU level of care. And the complications there can include muscle breakdown, infection of the heart tissue, what we call cytokine release syndrome or cytokine storm, acute respiratory distress syndrome, where the lungs fill up with fluid and are very inflamed, and shock, which basically means that one's blood pressure drops and you need medications to maintain that pressure. Some people with mild symptoms initially actually deteriorate, and that happens usually about a week into their illness when it's going to happen. And for those people who have risk factors for severe disease, they really do require close monitoring for that first week to make sure that that doesn't occur. Next slide. So the incubation period is anywhere from 2 to 14 days, but the median time from the time of exposure to the time of symptom onset is about 5 days. Thereafter, if someone is going to become symptomatic, they generally start out with non-specific symptoms, so things like fatigue, not having much of an appetite, some body aches. People can have gastrointestinal symptoms early on and or sore throat, and then of course at some point fever is a highlight of this syndrome. And then around day 7, as I mentioned, people can become very short of breath for those who are going to have a more severe course of lung disease. And then around day 10 is when the critical illness really sets in for that proportion of patients who do become more severely ill. Next slide. So there are a number of risk factors that we've identified that put people at higher risk of having severe disease. That includes all the things listed here, so diabetes, any sort of cardiovascular disease, older age, so particularly over the age of 65, obesity, chronic respiratory disease or any sort of underlying lung condition, high blood pressure, and anybody who is immunosuppressed due to cancer therapy, an organ transplant, HIV, or is on medications for some other reason that significantly suppresses their immune system. Next slide. So in terms of laboratory and imaging abnormalities that you might see, so for those who are in the hospital, we often see a low white blood cell count and elevated markers of inflammation. So I've listed a number of them here. One interesting one to note is this interleukin-6, which is one of the many molecules involved in the inflammatory process in our bodies, and that's been a target of some therapeutics, which is why it's worth noting. Procalcitonin is a test that we sometimes use to discern sepsis or a bacterial infection from a non-bacterial infection, and that level is typically normal in many patients, although in some circumstances can be elevated. Things that are associated with poor outcomes in terms of laboratory tests when we see them. So people who actually have a higher white blood cell count, that's not a good sign. People who have a low lymphocyte count, also not good. Abnormal coagulation factor, so this is what allows our blood to clot properly. People who have a liver injury or have very severe elevation of the other inflammatory markers that I mentioned. On imaging, you can see I've put some pictures here for you. The typical appearance is these rounded ground glass areas. So we call them ground glass because if you look very closely on a CAT scan, they sort of look as if somebody ground up some glass. And they are often rounded, and they can either be central, as in the top picture, or they can actually be at the edges of the lungs, like on the bottom picture. And we do try to avoid CAT scan when we can, because you can often make the diagnosis in another way. But you can see this if you do a CAT scan on patients. And you can also see chest X-ray or ultrasound abnormalities that reflect the same disease process. Next slide. To diagnose SARS-CoV-2, we use a nasopharyngeal PCR. So that's a polymerase chain reaction. So that is the process by which we actually isolate and amplify the virus itself, the actual RNA from the virus. So if we do this test early on, the sensitivity is anywhere from 60 to 80%. So it really depends on when you do it. And the technique that you use also matters. So if you get really deep into the nose, get a really good sample, your chance of having a positive result is higher. But you can sometimes have false negatives, and so we have to have a high index of suspicion, particularly when there's high levels of disease in the community. Alternatives to the nasopharyngeal PCR, which as you can see in this picture is maybe not the most comfortable thing to do. Some people have used oropharyngeal PCR, so that just means a throat swab like you would get for strep throat. Also, using a swab that goes just into the front of the nose as opposed to all the way back has been used, and certainly can facilitate easier testing of somebody at home or for a healthcare worker to test themselves. But the yield on those tests is lower, so the sensitivity is lower, and that's the limitation. Likewise, antigen tests. So that's looking for a particular protein of the virus. It has lower sensitivity, but is an option. And antibody tests are available. They do have some limitations. The sensitivity and specificity of that test depends on the platform, and there are many. And the antibody test is only going to turn positive if it's going to turn positive at all 7 days or more after the infection has started. So it is limited, and it's a better tool to diagnose somebody who had a negative nasal swab but you suspect disease. Next slide. So severity of illness, certainly people who have a low oxygen on room air have a more moderate disease or more severe disease. But for people who are really getting to the severe or critical category, they have an elevated respiratory rate, low oxygen saturation is very low, requiring extra oxygen. They may have more than half of their lung involved in the disease. And they can range from needing just a little bit of oxygen through a nasal cannula or all the way through to needing to be on a respirator and every step in between. For people who have the most critical illness, we find that they may have cardiovascular collapse requiring medications and machines to support their blood pressure and oxygenation. They may have multi-organ failure requiring support like dialysis, etc. Next slide. So the complications of COVID-19, we're still learning about this, but one of the very striking features is thrombosis. So blood clots are a common feature, and they can happen all over the body. And one of the things that really impacts people who have severe lung manifestations is these pulmonary emboli and deep vein thrombosis. These are blood clots that end up in the lungs. Some of them can start in the legs and travel upwards, but some of them are actually occurring within the lung itself. Likewise, a myocardial infarction, which is a heart attack, that's something that can also happen in COVID as a result of this dysregulation of clotting. And likewise, a stroke. So strokes are increasingly identified in people who have active or recent COVID infection. The rate of renal failure, so kidney failure, is something that we were sort of taken aback by when we had our surge in New York City. The rate that people required renal replacement therapy with dialysis for those in the hospital was about 30%, which is really significant. Also, people suffer from arrhythmias and sudden cardiac arrest, where suddenly their heart rhythm is abnormal and they can actually have their heart stop beating and require resuscitation. Neurologic changes, so issues with brain or cognitive ability or confusion, very common. Cytokine storm, I mentioned earlier, this is when people have high fevers, very, very high levels of inflammation, and the body's own immune system begins to attack the organs of the body. It's very difficult to manage. Some lung injury has been noted in certain patients, unclear how much of this is reversible at this point. And of course, healthcare associated conditions can happen due to prolonged hospitalization and ICU care, like anyone else who's severely ill. Next slide. So this is a unique feature in pediatric patients that's worth mentioning. Pediatric multisystem inflammatory syndrome associated with COVID-19. It's a mouthful, so we abbreviate it PMIS-C. So this is a syndrome that occurs in children. It is rare, but it has been well documented at this point. It is similar but different from something called Kawasaki disease, also an inflammatory syndrome. And the features include a fever. In the definition that's been issued by the Department of Health, it also includes hospitalization and organ dysfunction, or a rash like you see in this picture, conjunctivitis, so redness of the eyes, gastrointestinal symptoms, or mucous membrane involvement. So that might mean things like ulcers in the mouth. These children have inflammatory abnormalities if you do laboratory testing, similar to what I mentioned earlier, and they have to have evidence of COVID-19 by some sort of approved laboratory test or a link to a patient who had COVID-19, like a family member or another close contact. There was a series that was shared by the Department of Health in New York where they looked at a number of children who had been reported in the month of May with this syndrome. They found that it was predominantly school-age children. About 71% of them required ICU level care. They can have respiratory failure and other organ failure. 19% of them required intubation, where they had to be on a ventilator. Thankfully, only 3 of these children died, but obviously that's still very, very troubling. And 87% of these children were positive on a test for SARS-CoV-2, either antibody or PCR or both. Next slide. So we're going to move on to the epidemiology of COVID-19 quickly. Next slide. So this is the current global picture, and as Dr. Racine shared with you, we really are at a very shocking point globally in this epidemic, and unfortunately the United States is bearing the brunt of this at the moment. So we're already beyond 9 million cases of COVID worldwide, and of those, over 2.3 million are in the United States, and we've had nearly 500,000 deaths globally, and unfortunately in recent weeks, Brazil is seeing a sharp rise in cases. We're also seeing a pretty sizable outbreak in India, which is very troubling, in other parts of South America and in Russia. Next slide. So the R naught is a concept of, it's the reproductive value. So it's how many other people are becoming infected from a single infected person in the current state. So early on, this was calculated to be between 2 and 3.5. So that means for one person, if I have COVID-19, you can expect that I will infect 2 to 3.5 other people. So you might imagine that that's a pretty brisk rate of transmission. To give you a sense, influenza is around 1. So it's more transmissible than influenza, which makes it an infection control challenge. And it is higher than SARS and MERS, which are the outbreaks that we have experience with in recent years. The other challenge is that infectivity, meaning the likelihood I will pass the virus to another person, is high early in the disease. And it can be before I know that I have symptoms, or when my symptoms are mild and I haven't yet realized that I'm sick, and so I'm still out and about. So this is also a challenge in terms of infection control. The host of the virus, so there is this initial link to wild animal markets in China, and SARS and MERS certainly had intermediate hosts identified. So palm civets for SARS and then the dromedary camel for MERS were the intermediate host for this coronavirus to pass through an animal into humans. SARS-CoV-2, it's unclear what the intermediate host is. It's clear that this originated from a bat virus, as in the other coronavirus outbreaks, but it's not totally clear what the host is. Pangolins have been implicated, but no one has proven this yet. Next slide. The way that SARS-CoV-2 is transmitted from human to human is a variety of ways, and we're still understanding how often each of these is a problem. So there is the potential for aerosol transmission, particularly if one is undergoing an aerosol generating procedure. So for instance, if you are receiving a nebulizer treatment, or you're receiving some kind of ventilatory support that actually causes small droplets to be released in large quantities, that makes it more likely that it will be transmitted in that way. Respiratory droplets appears to be the primary way that this infection is spread. So respiratory droplets are larger droplets when we cough, sneeze, talk, sing, etc., in close proximity to other people. It is also possible for SARS-CoV-2, we think, to be transmitted via contact and fomite. So that means if I wipe my nose, or I touch my mouth and I shake hands with you, or I touch a surface and then you touch that surface and touch your nose or mouth, that the virus could be transmitted that way. I think we've discussed how zoonotic transmission, so from animal to person, is likely the way this started. It is unclear how often animals can transmit the virus on an ongoing basis to human beings. So thinking like a cat or a dog or some other animal, we don't know how often that happens. Fecal oral transmission, so this is the concept that the virus lives in the gastrointestinal tract and can be actually transmitted that way. We don't know how often that happens. The virus that is isolated from stool is often not viable, but in some cases appears to be viable. So this is still an unanswered question, but we are assuming that this is possible. And then nosocomial transmission is a concept that within a healthcare facility, when you have many people concentrated in one place with the same infection, it is possible for the virus to be transmitted in all the other ways that I mentioned and additional ways when we share equipment or other things in that setting. Next slide. So what we know is that the incubation period is usually around 4 or 5 days, but can range from 2 to 14, and that about 97.5% of those who are going to become symptomatic will become symptomatic within about 11 and a half days. So most people are going to get sick by that point. The case fatality rate really varies, and it depends on many things, including the healthcare resources available in that setting, the demographics of the community, particularly age and comorbid conditions. It's somewhere on the order of 1 to 3% if you look at the entire population. But if you look only at those who actually require mechanical ventilation, so the people who need the most respiratory support, we're looking at 40 to 80%, which is a very significant mortality rate. Next slide. So in terms of preventing and controlling SARS-CoV-2 in the community setting, there's a number of things that we can do. So mask wearing, hand hygiene, so frequent hand washing, social distancing techniques, frequent testing and aggressive testing and contact tracing of anyone found to have the virus, and isolation of those at home is very, very helpful. And really, we talk about all these things as if they're equal, but in truth, I think they are of varying efficacy. And so I like the diagram to the right, which is sort of a more hierarchical view of what is most helpful from a population point of view in terms of controlling the virus. So staying home is actually a very robust strategy because it just decreases the chance that anybody is going to be exposed. And then, of course, things like only leaving home for groceries, hand washing, staying 6 feet from other people, and masks, they're excellent additional controls if we can't completely stay home, but probably less robust. Next slide. In the healthcare setting, this becomes much more complicated. As I said, you have a concentration of people who all have this virus in very close proximity to one another. And so we have to do things a little bit differently and be very aggressive. So one of the things that we focus on always in any sort of outbreak or even the risk of an outbreak is to identify, isolate, and inform. So that means we have to have active processes by which we screen people who are coming into our facilities for any reason, for any potential exposure, travel, symptoms, no matter what it is. We have to be able to identify them as early as possible, because the next thing that we then do is to isolate them properly and to inform others around us to take precautions. Engineering controls are very important in a healthcare setting. So this is, the idea of creating a negative pressure environment so that you don't push out infectious particles into a hallway. So that means the air gets sucked into a room. Also the use of HEPA filtration, so that as the air exits a room, it's being filtered and those infectious viral particles are being filtered out of the air. Things like that we take very seriously and are a big part of how we control all sorts of infections in that environment, including COVID-19. We, of course, isolate anybody who we believe to have COVID-19, and we use special precautions. We put signs on the door. We communicate about, what needs to be done for that person and how to do it safely. We minimize how much time they have to spend outside of that room, all to try to prevent any potential exposures. And lastly, we use what's called transmission-based precautions, which is all of the personal protective equipment that you see listed here, essentially to create a barrier for the provider to prevent them from being exposed to the virus while taking care of that patient. We use different materials in different settings with different viruses. Next slide. There are a number of barriers to effective control, which I probably don't need to tell this group, but the economic impact of social distancing has been substantial globally. The global shortages of PPE and other critical medical supplies, autonomy of different states and regions and countries leads to variation in both the implementation and adherence to public health recommendations. Obviously, political pressure can be something we have to contend with. International commerce and travel is much more common in the current era than it used to be, and makes the spread globally of viruses like SARS-CoV-2 more likely. Obviously, socioeconomic status influences how and in what way a person is able to protect themselves from this virus. And then population density and housing certainly has played a role in New York and in other areas affected by COVID-19. Next slide. That is all I have. I just want to say thank you very much again for the opportunity to speak to you, and I'm happy to take questions at the end of Dr. Zingman's talk.
Great, thank you very much, Dr. Madaline. So stick around, we'll have you back. And we're going to transition now to Dr. Zingman, who is the clinical director of infectious disease. And in that position, you and your team are actively studying vaccines, antivirals, and other therapeutics. In fact, you are the principal investigator of Montefiore's clinical trials of remdesivir. So maybe you can bring us up to speed and give us the clinical facts regarding the state of the cure against COVID-19.
Great. Thank you, Mr. Kennedy. Thank you to the GIC. Thank you to Andy Racine and Theresa Madaline for teeing it up so amazingly and presenting such a wide range of COVID-19. So I'm going to talk about what we know right now about therapeutics and where we're at with vaccine development for COVID-19. Next slide. So Dr. Madaline very nicely laid out what is densely in this slide, which I just want to point out the red line and the blue line. So the red line, we know that the virus is very active early in the infection, and then the virus becomes less active with time, and then there's a second phase of inflammation. Inflammation varies from person to person. It may be very mild in mild illness, but it may be very severe in severe or critical illness. And so this leads to many of the treatments that we have, whether they're aimed at the virus, aimed at inflammation, or aimed at other complications that Dr. Madaline so nicely went through and are mentioned at the bottom of the slide. Next slide. We've also learned a tremendous amount about the exact steps in the reproduction of the SARS-CoV-2 virus. We've been able to learn multiple steps in the viral replication, and there's a long history in developing antiviral medicines of determining what are those steps in the growth of the virus, and then targeting medicines at those specific steps, one or more, and in fact sometimes targeting multiple steps in the viral replication cycle can lead to even more effective therapies. So we've been able to identify multiple therapies now aimed at different steps in the cycle from when the SARS-CoV-2 virus binds to the receptor, the ACE2 receptor, as Dr. Madaline said, then enters the cell, replicates inside the cell, and then buds off. Next slide. And she mentioned as well those spike proteins here in blue, those spike proteins and the way they bind to the ACE receptor and the temperase protease inhibitor on the surface of the cell have become major targets for some of the therapeutic agents that you've heard about, and is the major target for the vaccines that are being developed. Next. So in the rest of this talk, I'm going to break it down for you into what is known right now about antiviral drugs, where are we aiming with anti-inflammatory medicines, some of the key symptomatic treatments that have been developed in the 7 months that this epidemic has been known, and then go into vaccines. Next. And next. So you've certainly heard plenty about chloroquine and hydroxychloroquine. This was a hoped-for agent. These were hoped-for agents. They are relatives of each other. Since the beginning of the epidemic, they have been shown really now definitively not to work. In basically every study that has been well done has demonstrated that they either don't work at all or don't work and have extra side effects. And so pretty much as of last week, most of the studies of these agents have now stopped, at least most of the big studies. Next. Around the world, other therapies are being used. Interferons are a therapy that has been used for other coronaviruses and is pretty widely available. And the virus in the test tube is pretty sensitive to interferons and certain of the medicines. And so there have been treatments with interferon with combination therapies. Here's a study of 3 drugs, interferon and 2 others, in which patients who got these 3 medicines together seem to do better than if they only got 2 of them without the interferon. But all of these are quite weak, and so that's part of the reason why you actually need to combine them together. Next. You've probably heard a lot about the different antibody therapies that are being highly researched. One of the big ones is convalescent plasma. Convalescent plasma means that you have somebody with proven COVID infection. They've gotten over it. They've produced antibodies to the virus, and then they go to they're taken to a blood bank. They undergo what's called plasmapheresis, in which the antibodies are isolated, and then those antibodies are given to another person, and this can be given as prevention after exposure or as treatment. There are many studies going on of convalescent plasma. As of right now, we know that it's a safe therapy, but it hasn't been clearly shown yet to be effective or how effective it is. One of the places that is studying this very well is Montefiore Einstein and in collaboration with other centers in the New York City tri-state area. Next. Other antibody therapies are also being used, something called hyperimmunoglobulin, where you actually try to hyper concentrate those antibodies from the convalescent plasma. And as well, a number of companies are developing what are called monoclonal antibodies. So it's developing synthetic antibodies to the spike protein on SARS-CoV-2. And a number of studies are starting for these monoclonal antibodies. Next. So remdesivir is an antiviral medicine that was developed for Ebola infection. And it was found at that time to be moderately effective for Ebola, but also that in the test tube, it was very effective against SARS, coronavirus 1 and MERS. And so it was identified early on as a potential candidate to treat SARS-CoV-2. It is highly potent against the virus, and in an animal model of COVID-19, it seemed to be effective. And so it went into large studies early on. Next. And the major trial of remdesivir in COVID-19 was published May 22nd in the New England Journal of Medicine. And this was a randomized double-blind placebo-controlled trial of remdesivir in hospitalized patients with pneumonia due to COVID-19. It was studied at 68 sites around the world, and we enrolled over 1,000 patients in this study. Next. And what was demonstrated was a significant improvement in those patients who got remdesivir. Patients recovered a mean of 4 days earlier. They recovered about 30% faster if they received remdesivir than if they got placebo. This was statistically significant and also very clinically significant. Next. The mortality rate in patients who got remdesivir was also lower. It was lower by about 30%. This was not statistically significant, but approached it. But we know from looking at all the patients who were in the study that the clearest benefit was in only certain patients who had pneumonia due to COVID-19 and needed oxygen. So if in patients who needed simply a low amount of oxygen, they recovered faster, and their risk of death was lowered by 78%. Next. However, for other groups, either people not needing oxygen, people needing high amounts of oxygen, or people needing mechanical ventilation, the results were not as impressive. And in people, the sickest patients who needed mechanical ventilation were on a ventilator, there were no differences at all. Next. The drug was very well tolerated. Next. And based on these actually, impressive results, and the first proven results to be able to effectively treat anybody with COVID-19, the FDA approved the drug for emergency use authorization for patients with severe disease, and Gilead is working throughout the world on FDA it's working in the United States towards FDA approval, and is working towards approval in other countries as well. But it does seem that we likely need to combine it with other approaches, because there were significant groups of people with COVID-19 who it wasn't enough for. Next. So remdesivir is the antiviral medicine that works specifically against the virus it's the only one that's been shown to be effective so far. There are many others being studied, but they are either way behind in their studies or aren't nearly as promising. Next. And so, as I mentioned before, we're targeting the virus, but also we know that in many people, we need to target the inflammatory response. And so that gets us into a whole nother class of therapies that are what are called host-targeted or immune modulators. Next. There's an antibiotic called azithromycin, which has broad, mild anti-inflammatory properties. It's been used all around the world for patients with COVID-19 because it's easily available. However, there's no convincing results that it works, and it is increasingly out of favor. Corticosteroids are an anti-inflammatory class of medicine that's been available for decades. These drugs are used for many different diseases, so they are very familiar. Before COVID-19, there were suggestions of mixed results with other coronaviruses. And so when we went into this epidemic, it was thought that except for certain people with very severe disease on a ventilator called ARDS, acute respiratory distress syndrome, that corticosteroids were probably not a good idea because in blunting the immune system might enable the virus to get more out of control. However, this was a significant question, and particularly since we began to appreciate how important inflammation was, steroids were being studied broadly. Next. And so just last week, a major trial results were announced, the so-called recovery trial from the United Kingdom, in which they had randomized about 6,000 patients to get the steroid dexamethasone or usual care. They will receive dexamethasone for up to 10 days. And what they showed was that patients were hospitalized for a little bit of a shorter duration if they got dexamethasone, but very significantly, they progressed less to mechanical ventilation. There was a strong trend there, and most impressively, they had a lower death rate. This was particularly seen in patients who were on mechanical ventilation, where their death rate was lowered by 35%, and it was lowered by 20% if patients required lesser degrees of oxygen. If they required no oxygen, there was actually a trend towards the patients doing worse. But overall, this was a very impressive drop in mortality that in many ways was even more impressive than the remdesivir data I showed you already. And also impressive because, as I showed you, the remdesivir was effective for people who are earlier in the disease, not needing mechanical ventilation, whereas steroids seem to be working at the other end of the spectrum. So potentially a very, very important finding here. Next. And so there are many studies. So the corticosteroids with dexamethasone is the furthest along with the strongest ALK results so far. But there are many other agents being studied to dampen the immune response to COVID-19. I've listed a number of different classes of agents on the right. There are literally hundreds of studies going on of different agents in these classes. and so far no results like I've just showed you with remdesivir or dexamethasone. Next. And so the natural question is we should be probably combining agents, agents like an antiviral and an anti-inflammatory. And so the group that's studying remdesivir has now moved into a second phase in which we are combining remdesivir with an anti-inflammatory agent, in this case a drug called baricitinib, which is in the group that I just showed you. And that study has enrolled about 800 of an expected 1,000 patients, and results should be available soon for that. Next. And so let me just briefly talk about symptomatic and supportive therapies. Next. The big issue here is, as Dr. Madaline mentioned, that we have learned about the morbidity and mortality that patients with COVID-19 are getting from clot formation. And this is clots in the veins, clots in the lungs, arterial clots causing strokes, and there are dozens of studies going on about what is the best approach to blocking these clots. Is it to use preventative therapies? Is it to use therapeutic strategies, higher doses? Which agents? Should they be combinations of agents? This is a very active area of research right now in the therapeutics of COVID-19. Next. And I'm going to close with a brief discussion about vaccines. Tell you, vaccines could be a 3-hour talk. But luckily we're relatively early, luckily for me anyway, in presenting to you, we are relatively early in the development of these vaccines. I'm sure you actually know, many of you know even more about this than I do, about how the US government and other governments have developed partnerships to help promote therapeutics and cure of COVID-19, and Operation Warp Speed and BARDA have been major players in the development of the COVID-19 vaccines. Next. And as I mentioned before, these vaccines are an attempt to create either antibodies or what's called cellular immunity to the spike proteins on COVID-19, on SARS coronavirus 2, that would help prevent it from fusing and getting into the cell. So this is the aim, to try to block that spike protein on the surface of SARS-CoV-2. Next. And this slide is a brief overview of the different kinds of strategies that exist for developing vaccines against infectious agents. So there are really 5 different main kinds of vaccines. Our most typical vaccines that have been approved over the last 50 years have been either inactivated or live attenuated. And so in the left-hand column, those 3 different kinds of vaccines, those are your typical vaccines for measles, mumps, rubella, influenza. Those are work intensive. They take a long time to develop. And so there's been the interest in developing new vaccine technologies. And those are the 2 on the right. So one is what's called an adenovirus-based vaccine, and then a nucleic acid-based. An adenovirus-based vaccine is one in which they actually take another virus, insert genetic material from the germ of interest, and then utilize the adenovirus to infect your cells and produce the proteins that would produce the immunity. So that's an adenovirus-based. Then nucleic acid-based is where you actually take the germ's DNA or RNA and inject it directly into the body. And then that DNA or RNA may be taken up directly by cells of the body, and then start to produce the proteins and the spike proteins, for example, naturally in the body, and then the body produces an antibody to it and a cellular immune response to it. So Adenovirus-based vaccines and nucleic acid-based vaccines are much faster to develop, but none have been approved so far. None have made it to the point of release around anywhere in the world. So these are very hopeful new technology, but are so far unproven, and exactly how to do them best, and specifically for COVID-19, is still being worked out. Next. So there are about 30 different vaccine candidates that are in various different stages of development. The 8 that I've listed here for you are, I think, would be considered to be the major ones. Next slide. And then there are 4 in particular. So 2 of them are adenovirus based, and 2 of them are RNA based. These 4 in particular are being heavily sponsored by the U.S. government, by Operation Warp Speed, to move quickly into phase 3 trials. And as you can see, the Moderna vaccine trial should be starting next month, the Oxford AstraZeneca vaccine in August, Pfizer in September, and the Johnson & Johnson vaccine should be beginning in September. And just as one example, at a site like ours at Montefiore Einstein, we expect to be studying at least 3 of these vaccines starting in the next 2 or 3 months. Next. Next. So there, no, one slide back, sorry. So we are very early, as I've said already a few times. We are very early, and we do not know how quickly these will be able to be developed, which one or more might work. Importantly, if they work, how well will they work? So what will be the degree of protection and the duration of protection? Exactly what will be the schedule? Will one shot work, or will you need boosters? Side effects, uptake, and costs and distribution. There are so many unknowns right at this second about these vaccines, but they are beginning, and one or more of them will work. We just don't know exactly when. So thank you.
Great. Thank you very much, Dr. Zingman. We appreciate it. So we're going to head right into the Q&A portion. So if we can bring up our other good doctors on screen, and then we can start with the questions. Great. So Dr. Madaline, this first one's going to be for you. Can you please identify a jurisdiction, any U.S. jurisdiction, where contact tracing is being done effectively?
That's a great question. I think that there's a lot of variation across the country in terms of where various jurisdictions are in their contact tracing programs. Part of that is that you have to train and deploy a large number of people to actually do that work, and the ability to do that varies. I think some jurisdictions are also struggling with language. In certain areas, people may be predominantly Spanish speaking or a different language, and so you have to have contact tracers that can effectively communicate. New York has definitely had a very concerted effort to build up their test and trace program through Health and Hospitals Corporation in partnership with the Department of Health, but they are still even building up the number of people that they need, but they are very actively contact tracing at this point. But one area that stands out to me is probably Northern California. UCSF really partnered with the Department of Health in California, and they started fairly early, and they have a pretty robust program there. So I think they are doing a pretty good job, and I believe also in LA, they have a very active program, again, partnering with University of California down there. So I do think of all the places that I've seen, their programs are probably the furthest ahead.
Great, thank you. Dr. Zingman, could you speak to the risk of mutation of the virus, and what are the implications for therapies and vaccine development?
It's a great question. We're still learning how much this virus will mutate over time. So this is actually, I think, an unknown right now. There are suggestions that the virus has changed already over time as it migrated from the Far East to other parts of the world, but that actually isn't clear whether or not the whether or not that is truly significant mutations that will affect the clinical course, or is it that we are better at treating it and earlier at identifying it? So absolutely, there, with most infectious diseases, there is a chance over time that the organism evolves, and so strategies do need to be able to treat that fact. And that's why in general we are looking for, in therapeutics, targets that don't vary over time. So for example, key targets in the replication cycle of every SARS-CoV-2 that can't be changed, or at least would be very difficult to change. And for an effective vaccine, it will need to be a vaccine response to what are called conserved areas on the virus that are extremely unlikely to alter over time, or at least alter significantly. But whether or not that works, we don't know. Another virus, HIV, has had a very high mutation rate, and that was a continuing challenge. That has been a continuing challenge for therapeutic development and vaccine development for HIV for the last 35 years. I don't think we have any evidence that coronavirus is likely to be as mutation prone like HIV, but it's a concern.
Thank you for that. So Dr. Madaline, considering the experience through COVID-19 to date, the question is, what must we do to prepare for the next round, the second wave? And maybe speak to what the second wave looks like. Is there a second wave? Are we entering the second wave? And what about the next virus, the next pandemic after this?
Great question. Well, I think we are really kind of still learning about what the second wave looks like. And unfortunately, I think that there's been a significant increase in activity in some parts of this country a lot sooner than all of us hoped for, including me. And so we may well be, as a country anyway, entering what will eventually be called our second wave. I am hopeful that some of that at least will be able to be contained, and that things like what's happening in New York right now, where they're really trying to be careful and use data to drive decision making, will continue to help to curb the spread. However, I do think that activity is clearly not dropping around the world, and that we do need to resign ourselves to the fact that this virus will be with us for some time. And headed into the fall and the winter, we have some challenges ahead, because that is typically the season where respiratory viruses circulate, and we may need to be addressing things like influenza co-infection, among others, which will be an additional challenge. I think that we've learned much from the wave in New York that can be applied to elsewhere. One thing certainly is to consider the equipment that one is going to need in order to serve the patients. So that includes things like, of course, personal protective equipment, but in addition, things like ventilators, other types of respiratory support equipment other than ventilators, and all of the things that go along with that equipment, the tubing, the masks. I mean, these things sound very small, but in fact, they're very important when they're in high demand. Also, certain medications were in very high demand during the surge here. Things like beds, cross-training your staff. So we learned that people needed to learn how to do different tasks than they're normally assigned to do. We have a period of time now where we have an opportunity to provide some training programs and some support and a toolkit to people who could be asked going forward to care for patients in that manner. And so I think it would behoove all of us in this country to really be thinking about things in that way, and to be providing that type of education and support. And I think also just thinking creatively about what will we do if we reach 100% of our capacity, 150, 200, we now know that that's possible. So thinking creatively about making plans in advance, practicing what you'll do if that does happen, talking, to your staff, communicating about that, preparing them, stockpiling the things that you can, understanding, that may be limited, and really just thinking creatively about how you'll alter your operations, what will you do about visitation, how will you contact trace how can you keep an eye on what's going on in the community around you so that you're ready to respond quickly? And how do you support locally, wherever you are, whatever testing and tracing programs are out there? Because the more aggressive those programs are and the more we can support them, the easier it's going to be to keep the surge from taking us by surprise. So those would be just some of the recommendations I'd have.
Fantastic. Thank you for that. All right, Dr. Racine, question for you. And there's a view that, and it's been reported that certain states are changing the way that they report hospitalizations, ICU capacity. And when I say change, in some cases they're withholding the information or not reporting at all. Can you just speak to the practical on-the-ground experience for you and the Montefiore health system, how it goes through that reporting process and how that actually works?
Sure. I can't speak to what's been going on in other states, but New York State has had a very robust reporting system in place almost from the beginning. Partly, I think it's because we had, at least in New York City, a very well-developed public health system. And reporting of all kinds of clinical activity has been part and parcel of what it means to run an institution like this in this state. So those were just, those reporting techniques and those reporting, if you will, pathways were just adapted for this particular condition. I will say that there have been some ambiguities. That is how it is that you determine what exactly a case is, particularly early on when our testing capability was somewhat limited. And some of that had to do with just being able to determine it on a clinical basis. But as testing has become more frequent, we've been able to actually confirm a lot of these things with molecular testing. And then we report daily on the number of patients in the hospital, not just us, obviously, the other hospitals in the state report daily to the state the number of hospitalizations, the number of deaths, the number of patients under consideration for this condition, and a variety of other metrics that they're interested in. So I would say, at least in New York, the reporting has been very vigorous and ongoing for this condition.
Great, thank you. Dr. Zingman, this one is for you. Will treatments, all treatments be injection only, or are there other delivery methods, prophylactic type of solutions?
No, that's a good question. So the first drug that has been available, remdesivir, is IV. But Gilead has already announced that they are looking at an inhalation version of it, and absolutely positively, there are oral agents that are promising as well, that we expect that are going to be studied for prevention, for early disease, for non-hospitalized patients. Certainly, the first efforts therapeutics were aimed at the sickest people most likely to end up on ventilators or die from COVID-19, and so that was the remdesivir, that was the IV or oral dexamethasone. But there are going to be many oral agents that we hope will become available, and also there could be depot formulations. That all different mechanisms of delivery are being looked at.
Great, thank you. Dr. Madaline, you showed those striking pictures of the lung and the glass shards that exist. Can you just speak to the effects of smoking or vaping, and do we know enough yet to know how that behavior impacts the results?
Sure. So I mean, again, like everything else, we're still learning, but I will say that, both smoking and vaping certainly result in lung damage and can result in COPD, emphysema, and for those who already have underlying asthma or lung conditions can significantly worsen those conditions. And so the expectation is that somebody, particularly who's smoked for some period of time where they've accumulated significant lung damage, that person would be at increased risk by nature of their underlying lung disease of having severe complications of COVID-19. So certainly I think that smoking is a big risk during this pandemic, and vaping as well.
Great, thank you. Dr. Zingman, this may be an ethics question, but when the vaccine does become available, how will it be decided who gets vaccinated first? What's the allocation process? How should we think about that, both in the early stage of production and further out once there's mass production?
Oh, that is really beyond my ability to answer. I don't even think I could start on that one. I'm sorry.
Nope. That's quite all right. We appreciate that.
Bill, let me just interject, because there are some guidelines with regard to other kinds of conditions in which the CDC and others identify what they consider to be vulnerable populations that might be targeted initially. And those include the kinds of people that you'd anticipate, folks who fall into a category either because of age or their chronic conditions or their occupations like healthcare workers. My guess is, and it hasn't been announced obviously, but when we get to that point, those are the kinds of populations people are going to be looking at first, be my guess.
So the vaccines the vaccine studies are being separated into those different groups. So I was reluctant to answer the question because there are so many factors that might be involved. For example, do they even work as well at first in the older population versus younger? I mean, are there other factors that influence, just which vaccine works and that vaccine's availability? So there could be many things that go into this.
Great, thank you both for that. Dr. Madaline, testing rates are rising, infection rates are rising, hospitalization rates are rising where they are being reported, but the death rates don't seem to be rising. Is it only a matter of time? And the question is, how much weight do you put on the infection rate versus mortality rate?
It's a good question. So obviously the mortality rate is going to depend on a number of different factors, including who is getting infected. So in some areas, although certainly not all, the age group of people who are primarily getting infected are younger persons. And so the likelihood that that person is going to die is substantially less. And so one would expect then that the mortality rate may not be high. However, that's not true of all places where this is happening. The other thing to consider is that mortality does tend to lag. Just because I get sick, 14 days after my exposure, it doesn't mean that, that's the same day that, I'm going to pass away. Sometimes, people are sick for sometimes weeks before they finally succumb. And so I do think it's a lagging indicator as well. I think in terms of testing and the increased rates, yes, of course, you will pick up more people the more you test, but that's an advantage rather than a disadvantage, because it allows, again, for effective contact tracing. And hopefully, if you can get to people who've been exposed and you can isolate those people, you reduce the chance that they're going to spread to additional individuals. And perhaps those people aren't at high risk, but someone they might give the virus to would be at higher risk of complications or death. So.
Great. So, Dr. Zingman, the question that's come across is the timing of a viable vaccine. I know there's some uncertainty around it, but what's your best guess and expectation? Fourth quarter of this year, sometime in 2021? Is it the first half, second half of next year? What's your view?
So, I mean, this is completely a guess. Obviously, the major trials are going to be enrolling about 30,000 people each, starting in either July, August, or September. So they expect to enroll about 30,000 patients each over the next month to 2 months, and then need to be followed over time to see the responses. The responses will be measured by blood testing, by measuring antibody, by measuring cellular protection in the body against COVID-19. And then ultimately, it will also be measured by rates of COVID-19 developing among those people. So I think it will, so this is a long answer to, I think it depends on how impressive those blood test results are over the first few months, because we won't know COVID protection probably that early. It will probably take more time for people to develop cases of COVID and then know whether or not there are significant differences in the attack rate of COVID between people who got the vaccine or placebo, but we are more likely to know blood test positivity for antibodies and the kinds of antibodies they've developed in the first few months. And depending upon how impressive those results are, and whether or not we believe that those correlate with immunity, the first vaccine could be out sooner or later. Okay, that said, it seems pretty unlikely to me that we will have something by the fourth quarter of 2020, given that we're almost in the third quarter of 2020 right now. It seems pretty unlikely to me. So I would say that if I had to bet, I would be betting on 2021.
Thank you for that. Okay, last question to you, Dr. Racine. What are the factors in the Bronx that cause such a high rate of infection and death that the Montefiore system has had to cope with?
That's a great question. And it has to do with a variety of different, what we would consider to be socially determined conditions. So we know that there's a high burden of disease apart from COVID-19 of the kind of conditions that make people susceptible to complications from this illness. So that might indicate why it is that the case fatality rate or the rate of hospitalization is high, but it doesn't tell you why it is that people would contract the disease at a higher rate. And there's been a lot that's been written about this, but it probably has to do with a combination of the housing stock and how many people are in a given housing complex or a given dwelling, because the closer people are, the more likely it is that they're going to be able to transmit infections from one to another. It may also have to do with the kinds of work that people who live in the Bronx do, and many of them were considered to be essential workers and had to go to work regardless of the fact that COVID was distributed throughout the community, and so they were more likely to be coming into contact with other people that had it. And I think there's also, despite all of the work that we've done, there are many people in the Bronx that don't have access to primary care and therefore may have been at risk for developing complications to the illness that other people might not have been. There are places in New York City where, as you know, residents of the city left. And to the extent that they had the ability to do that, that means that the likelihood of contracting the illness and suffering the complications from it was much less. But that's not an opportunity that people in this part of the city actually had. So it's really probably a combination of a bunch of things that led to that.
Great. Well, unfortunately, we're going to have to leave it there. Dr. Racine, Dr. Madaline, Dr. Zingman, thank you for captivating discussion, very informative. And thanks for spending time with our GIC community. We want to thank each of you individually, but also all of your healthcare colleagues for what you have done and continue to do in the fight against COVID-19. Thank you very much. Please be safe.
Thank you, Bill.
Thank you.
So audience, before we close, just a quick reminder, our next program is going to be in July, just after the July 4th break. We'll be exploring the pandemic's impact on agronomics, the food supply chain, and food security. So please watch your email for the invitation and the save the date from the GIC. Finally, a feature of the David R. Kotok Global Healthcare Series is Mr. Kotok has established a very generous matching donation challenge. Through July, any donation made will be matched dollar for dollar up to $50,000. So in other words, your donation of $250 becomes $500 in value and impact. All donations go directly towards bringing high quality program in this for the. To learn more about membership or to take advantage of the donation match, please go to the GIC's website at www.interdependence.org. As we conclude, I encourage you to take just 60 seconds. Please respond to our audience survey. Let us know how we can improve our programs. Your feedback is very important to us. Thank you for your attention and good afternoon.